2. All right. See if you got some good levels there. All right, can y'all hear me out there? Yes? Yes. That's better. Wow, that sounds awful. I don't like hearing myself like that. All right. You good? You good now? Good now. All right. Should we give everyone another minute or two to sit down after they get their lovely lunch? 2 more minutes? Roger that. How much traumatic brain injury do y'all see here? Just out of curiosity. Some? None? Nah, some. Okay. I don't know why they asked me to talk about TBI, but we're talking about TBI today. So, yeah. Something different, right? All right. Yeah, it's a little bit of feedback. He wants me to talk to you for a second. Well, I'm just a little bit of introduction. I'm Patrick Beausarge. I'm one of the trauma surgeons at UAB. So I've been there for about 5, going on 6 years. Had a kind of a interesting route getting to Birmingham. I'm originally from Mobile, and then grew up down there. Went to Bama for undergrad, South Alabama for med school. Did my residency there. Somehow found my way out to California, sunny San Diego, for my fellowship, where I did trauma and critical care, and then went back to work in Mobile for a little while, and then up to Tennessee for a little while, and now I'm here in Birmingham. Damn glad to see all of y'all. Everybody, all of these smiling faces, looks good. It's good. All right. Okay, so still another minute or two? Yeah? Yeah, okay. Live presentation. Good. You can edit all this out, right? Yeah. Sure. So we've got some doctors in here, and I heard that we have a very large PT-OT contingency. We have some nurses in here, I see, yeah, okay. Kind of a mixed bag of everybody. All right, excellent. Go ahead. Okay. All right, well, we'll go ahead now. So like I said, today we're going to be talking about traumatic brain injury and specifically kind of related to the critical care management of TBI. And so this is something that is near and dear to my heart. I love traumatic brain injury. I love to take care of these patients. And one of the main reasons is because TBI is a major cause of disability and death and economic costs to our society. Essentially, our central concept is that brain damage from TBI does not occur only at the moment of impact, so not does it occur when you fall out of your wheelchair or from your 15-foot ladder and hit your head, but it continues to evolve over the course of the resuscitation of the patient. And so what happens to those patients in the next hours to days after they strike their head or have their TBI really affects what their outcome is going to be like. So we know that if you improve what we're going to call secondary injuries, those things that happen after the initial injury, if you improve those things or limit those, the outcomes are much, much better. So this is one of my favorite charts from the CDC. This is basically the 10 leading causes of death by age group in the United States. This is one from 2010. Not that this presentation is that old, it's just the most recent one I could find. And what you're going to see from the age of 44 back to the age of 1, trauma is the leading cause of death. All right, so most people may not realize that, but trauma is a big deal. It's a huge deal, especially in the younger groups. Specifically, going back to this, it's probably the cause of most years of productive life lost. So, all of the other things that we talk about as far as cancers and heart disease and strokes and things like that, that all affects people who are older in age. So trauma is what wipes out all of our young, healthy workforce. Not that people in their, as I'm pushing older, I realize that people in their 50s are still productive, right? Sorry about that. Right here, okay. So the epidemiology of TBI, there's approximately 1 million head injuries that occur in the United States each year that actually seeks medical attention. So there's more patients that are not going to be seeking medical attention, but it's at least 1 million. About 3/4 of those patients are going to be categorized as mild, so they're going to have a GCS on presentation to the emergency department or doc in a box or whatever it is of 13 to 15. So about 60,000 deaths result from TBI each year in the United States, and about 80,000 patients are permanently disabled related to traumatic brain injury. Falls continue to be the leading cause of TBI in the U.S., just right out of the third. And it's about 50% of the TBI among children are related to falls, and 61% of the patients that present with a TBI older than the age of 65 have their injury from fall. Motor vehicular collisions are the second leading cause of TBI, but it's the largest percentage of what relates to TBI death. So here are the leading causes of TBI in a pie graph, and as we said, falls is number 1, MVC is number 2, struck by or against some kind of object, whether you run into a wall or baseball hits you in the head or a football player lays you out, whatever. And then assaults are 10%, and then we have a large percentage that is just not classified for whatever reason. Costs, what does it cost? So about $9 to $10 billion per year is related to the treatment of traumatic brain injury. So the average lifetime cost of someone that has a TBI that is disabled is about $2 million per year per patient. Or I'm sorry, $2 million for the lifetime cost of that patient. Overall, that's about $100 billion just in taking care of people for their lifetime after TBI as a large group. All right, so we're going to transition a little bit and talk about goals. Since we're all some kind of medical provider, what are the goals of acute inpatient care? And what we want to do is we want the patient to have a good outcome. That's what our goal is, right? We want our patients to do well. So the question is, what's a good outcome? Well, that's a complicated answer, quite frankly, because a lot of these patients, if you're not just overtly, neurologically devastated, you can have you can still have lots of other problems related to cognitive impairment, unemployment, depression, psychomotor slowing. All of these things occur in patients who may have minimal physical disability. So they have their TBI, let's say it's a moderate TBI, so their Glasgow Coma score is around 12 when they come in, and they get better, they get their PT, they get their OT, they're getting their things that they need. Well, they get over all of that stuff. They can walk again, they can write again, they can speak again, but they still have all of these other problems. So what most people quote in the literature is that there's about a 33% cognitive impairment that occurs, that lingers on after someone has a mild to moderate traumatic brain injury. And about 60% of all of these patients as a group will not ever be able to be employed again. So that's why it costs so much. All right, so for the doctors and the nurses in the room, let's talk about some pathophysiology. All right, so what is primary brain injury? That's what happens to the brain when the head strikes some other object, okay? It's caused by direct impact. So what you have is damage to the brain parenchyma, the skull, the meninges, the dura, and the blood vessels. And this can result in a space-occupying contusion or hematoma that consequently leads to cell death. All right? So I'm going to just show you some slides of the things that we see most frequently as far as traumatic brain injuries. And you don't have to have just one, or you're not limited to just having one. You can have multiple of these things happening at one time, so it can be a complicated picture. The first one I'm going to talk about is diffuse axonal injury. Basically, that's a period of parenchymal tissue damage. A lot of people call it shear injury because basically what happens is when the brain is jostled inside the skull, the brain can kind of shear upon itself. And what that causes is it causes direct axonal death. And so this is a CT scan over here, and you don't really see too much, maybe a little bit of a little blood streak right there. But when you get an MRI, you can see that there's actually little holes that can develop where these axonal tracts have been sheared, and thus they die. And this is what it looks like on autopsy specimen. These patients have a very, very wide presentation when they come to the emergency department or come to the hospital. They can be seemingly normal. Some people might say, oh, well, they're just concussed. They can be neurologically devastated and have a GCS of 3. It's that wide of presentation for these patients. And it all depends on where these axons are injured and what pathways they take out. So that's one. Intracerebral contusions is another one we like to talk about. Now, this is where you have an injury that's much like a baseball bat hitting someone in the head. We talk about coup and contra coup injuries. The coup injury is where the impact of the skull is with whatever object is being impacted. And then the contra coup injury is where the brain jostles back in the back of the head and hits the back of the skull. And it causes an injury to the back part of the brain. So you can see here, this is a CT scan that has a nice representation of an intraparenchymal contusion. And this is what it looks like on autopsy. Nasty. Epidural hematomas. This happens in about 5 to 15% of all TBIs. What frequently happens is that you get a skull fracture over here on the sides and you get a tearing of the middle meningeal artery. And so what classically forms is this lenticular structure here of blood, that's what this is, that pushes the brain in. You can see that the brain is, you have the bleeding here, the epidural here, you have some cytotoxic edema and swelling that occurs, you have midline shift, you have the ventricle shifted over to the opposite side of the injury. This is a neurosurgical emergency that needs immediate decompression. All right. And then you have subdural hematomas. This is what we see most commonly in our elderly patients. This can happen in up to 20 to 63% of patients, depending on who you read. And basically what happens is that you have rupturing of the bridging veins that go from the dura into the brain. And this happens most commonly in the elder population because their brain atrophies. Everybody's brain atrophies as they get older, so there's more room, more ability for motion, so those veins are more likely to get torn. This can also be a neurosurgical emergency that might need to have decompression depending on the thickness of the blood that's present, the amount of midline shift, and whatever else might be going on with the patient. The next one I'm going to talk about is subarachnoid hemorrhage. So it's common, it's very common actually, and it's associated with a poor outcome. We know that when you take animals and they have increases in ICP and or they have increases in ICP and decreases in cerebral blood flow independent of any mass effects. So the very nature of having a subarachnoid hemorrhage there causes the poor outcome. Mainly, it's most commonly thought due to vasospasm that occurs associated with the subarachnoid. So the blood itself is irritating. It causes vasoconstriction of the blood vessels, and that leads to decreased flow to those areas of the brain. And the last one I'll talk about is vascular injuries. Blunt cerebral vascular injury is something that we used to think only very, very rarely happened, and like 0.1 to 0.2% of patients that come in from acceleration, deceleration injuries, meaning like motor vehicular collisions or fall from height or things like that. We now know it's about 1 to 2% of patients. It's a lot more common than we thought. We see a lot of these at UAB. And what we'll see is patients that have carotid injuries or vertebral artery injuries. And what happens with this is that you have these little intimal flaps that develop that can actually lead to stroke. So you'll have a normal, this is not that long ago that we had this case, a normal appearing 19-year-old coming in. He looks okay. He didn't have any of the mechanisms that would suggest that we would need to screen this patient for blunt cerebral vascular injury, and lo and behold, he strokes out. 18, 19 years old, stroke. Now he's got a big stroke. And it's because he developed a little flap somewhere in the vascular system. You can also, of course, have penetrating skull injuries, whether it's gunshot wounds or stab wounds, and that can affect any vessel. All right. So let's talk about secondary brain injury a little bit. So what are we talking about? Destructive changes that evolve over time, and they're caused by these types of things. They're caused by elevated intracranial pressure. They're caused by hypotension. They're caused by hypoxia. They can be exacerbated by fever and seizures. Hydrocephalus can affect secondary brain injury. Vasospasms, like we talked about with the subarachnoid bleeds. And then, of course, infections of the brain can also contribute to these secondary brain injuries. So the first one we're going to talk about is causes of increased ICP, because this is most commonly what we're treating. So you have essentially a mass effect that occurs from the brain injury, from the primary brain injury. So you take that hit to the head and you get this big Goomba inside of your brain or outside of your brain, okay? What that does is that itself takes up space, but it also leads to edema, okay? And that edema is either cytogenic or cytotoxic edema, meaning that cells are breaking down and that's causing edema, or it's vasogenic edema, meaning that you have some kind of disproportionate flow problem to the brain that's causing edema in that area. You can also have increase in venous pressure. That can cause an increased ICP. So the patient has a constrictive collar on. You know, all of our patients are coming in with TBI, frequently they are anyway, with some type of cervical collar. You know, if you block off the jugular veins, then you can have an actual increase in your ICP. You can have obstruction to CSF flow and absorption. We call that hydrocephalus. That can be due to a blood clot that goes down distally and blocks off the flow distally. And you can also have an increase in CSF production. You can have some type of irritation inside of the area of the brain that produces CSF, whether it's an infection or something like that related to whatever may have happened to the patient, or maybe even something that we did, like put a ventricular catheter in. That can cause that. So this is all based around what's called the Munro Kelly hypothesis. Basically, these were two Scottish surgeons that lived in the 1800 range and came up with the idea that the volume of the adult cranial cavity is non-compliant and it's fixed. We don't have sutures in our skull doesn't come apart like an infant does, right? So it's a fixed volume, all right? So we have things in our brain that have to be there. Number one, or things inside our skull that have to be there. Number one is brain parenchyma. It takes up about 80% of that volume. And we're talking about both the intracellular volume and the interstitial volume, okay? 10% is cerebral spinal fluid and 10% is cerebral blood volume, both arterial and venous. For our ICP, which normally is between 1 to 15 to be constant, the sum of all those volumes inside the skull, which is a fixed space, have to remain constant. And if they don't remain constant, then something bad's going to happen, all right? So this is just a diagrammatic representation of what I just said. You have the brain, you have arterial blood, venous blood, and CSF. This is normal. Everything's in check. You add something to it, like a mass. It can be a mass, like a cancer, or edema, or blood. Then something has to go down in order for this to be compensated, all right? Compensation is what allows for this compensation, or being allowed to allow some of this venous blood and CSF out actually will maintain the ICP relatively normal until the point where all of your compensatory mechanisms, your release valves, if you will, are gone. And then you start seeing rises in ICP. So again, ICP is normally less than 15. We see pathologic changes when ICP goes greater than 20. All right? And the compliance relationship is nonlinear, okay? It's logarithmic or exponential. So once these compensatory mechanisms are exhausted, then just a very small increase in volume will result in a large increase in pressure. So some of the other compensatory mechanisms that we have that are built in, like I mentioned before, you have an age-acquired space. There's this space in between the gyri and the sulci of the brain. That's what makes the brain look wavy, right? And then the ventricles themselves, they contain the CSF that gets pushed out. So as those ventricles get smaller, that CSF is getting pushed out of the calvarium, out of the skull. We also talk about cerebral perfusion pressures. Cerebral perfusion pressures are basically a surrogate for the adequacy of how well the brain's being perfused. The way we calculate cerebral perfusion pressures, we take the map and we subtract the ICP from it. There is an autoregulation that we normally have, and so that the cerebral blood flow, it remains pretty constant over a very wide range of blood pressures. And so what you can see here, or cerebral perfusion pressures, I guess I should say. So what this diagram represents is that this solid line is the normal line, is that cerebral blood flow measured in mils per gram per minute remains about 50 until you fall below a cerebral pressure less than 40, 45 or so. It starts trailing off. And the reason that's important is because as it gets lower, you have more cell death. You have more secondary injury that occurs. More brain is being lost as that occurs. Interestingly enough, it's all, we used to think that one size fits all, but it doesn't. If you have a patient that has chronic hypertension, that graph actually is shifted over to the right, so that you actually need to maintain higher cerebral perfusion pressure for these patients who have chronic uncontrolled hypertension. So as a result of the TBI, not only does the area around the primary injury lose its ability to autoregulate, You also have areas remote from the original injury that can also lose its ability to regulate, so that changes in the cerebral perfusion pressure are paralleled by changes in cerebral blood flow. And what that means is it's kind of related to something I said earlier about the vasospasms, is that you can get this vasogenic edema that occurs in areas distant from the actual area of injury itself, if that makes sense. So let's talk about the therapeutics for TBI. What are we doing? What are we trying to do? We're trying to prevent secondary injury. We can't do anything about the primary injury unless we're a neurosurgeon and we can drain one of these blood occupying spaces, whether it's an epidural or whether it's a subdural, or whether it's like a temporal lobe that's just destroyed. You can sometimes take that out, and that will help. All right, so we're trying to prevent that hypoxic brain injury, and we're trying to prevent worsening cerebral edema. That's what all of our drugs and therapeutics are basically trying to do. All right. So we have a standard ICU bundle. Anybody that works in the ICU knows this. It should be pretty common knowledge now in the year of 2018, since this has been written for about 20 years. Bundles help people. Head of bed elevation is important. Not only is it important for all of ICU patients, if you can raise their head of bed for VAP prevention and things like that, or nosocomial pneumonia prevention, but it also helps specifically with traumatic brain injury, because you're allowing gravity to do its job and try to drain some of this CSF. Stress ulcer prophylaxis, TBI patients that are ventilated have a higher incidence of developing bleeding related to stress ulcer, so we want to prevent that. Oral care, that makes sense. You want to keep their mouth clean. Nutrition, that makes sense. You want to feed them, give them nutrition so that they can heal. Glycemic control probably is the one that is under-recognized as being important. There are some very large studies. One that said, by Vandenberg, said that we really need to be having tight glycemic control. There was another one that came out called the Nice Sugar Study, said, no, that's too dangerous. We really shouldn't do that. It's probably underappreciated in traumatic brain injury patients. And I can talk about that for a long time, but I won't because it's boring. And then, of course, DVT prophylaxis is something that's part of a standard ICU bundle that everyone should be, taken care of. So our neuroprotective strategies: blood pressure should be monitored and hypotension should be avoided. So we know from Chestnut that if your systolic blood pressure falls below 90, between the time that you're injured till the time that your resuscitation is complete, you have an increased mortality by 33%. That's huge. That's absolutely huge. Likewise, by Chestnut, oxygenation should be monitored and hypoxia should be avoided. That's maintaining an O2 sat greater than 90% if you can. Sometimes you can't. We recognize that, but if you can, you should, and you should adjust the ventilator to do so. PaO2 less than 60 also increases mortality in these patients. We want to treat fevers. Why? Because fever causes an increase in metabolic rate and thus the oxygen requirement. So the oxygen that you are providing to the brain is being used up because you have this hypermetabolic situation. So we know that hypothermia increases mortality. You also want to provide seizure prophylaxis for these patients. We don't want them to have this overexcited seizure activity for the same reason. We don't want the metabolic rate of the brain to go up. So every patient that comes in with a TBI gets at least 7 days of Keppra. It's mandatory. Brain Trauma Foundation guidelines. We do not give steroids for TBI. It doesn't help. It actually worsens your outcomes. Treatment of intracranial hypertension, that's our mainstay of what we're trying to do in the neurointensive care unit. And that's either elevated ICP or decreased CPP. Okay, remember CPP is CPP equals MAP minus ICP, so they're directly related. And you can talk about it either way. ICP is obviously determined. You have to have some kind of measuring device, some kind of monitoring device to know what the ICP is. So the standard of care is to place a ventricular catheter in. And the reason we like ventricular catheters is that not only do you get a number, so it's diagnostic, but you also have a therapeutic outlet. Because it's a catheter, you can actually drain CSF. And so that's why the ventricular catheter is what should be placed in these patients that have severe TBIs. The ventricular catheter, that's a cheap little tool. You know, it's a catheter that goes in, basically create a burr hole, stick the catheter down into the ventricle, through the brain and into the ventricles, make sure that it's draining, and then you hook it up to a pressure monitor just like you would an A-line. That's it. And the great thing about this one is that it can be recalibrated in situ. There are some things that we use sometimes called Camino monitors. Sometimes people call them bolts, which are intraparenchymal monitors. They're not preferred because you can't do the drainage that we like to do. So we try not to use those. We only use those in very, very, very rare instances. We don't normally exchange these catheters, and we don't normally have these patients on prolonged antibiotic therapy because it doesn't really seem to reduce infection. It's not recommended. So our goals of care. We want to maintain our ICP less than 20 and maintain our cerebral perfusion pressure greater than 60. So the first tier management that we use is pain management and sedation, okay? Mild hyperventilation. And we're going to talk about all of these in a little more detail. Hyperosmolar therapy, paralytics, and then the second tier management are barbiturates, decompressive craniectomy, and hypothermia. All right, so sedation. So this is rule number one, that when the patients come in and they have significant traumatic brain injury and they're intubated, because we're not putting people on propofol unless you're Michael Jackson, not putting people on propofol without being intubated. These are our two go-tos, fentanyl and propofol. We like fentanyl because it doesn't affect the blood pressure as much as morphine, and it goes away faster than Dilaudid does. Okay, so it's got a better safety profile. As a matter of fact, that's our primary narcotic of choice in our ICUs, in both the TB ICU and the neurointensive care. TBI is trauma burn ICU and the neurointensive care unit for trauma patients. We like propofol because it's a sedative. It's a great sedative, but it also has the added benefit of having an effect on the actual ICP itself. So if you take two patients and you sedate them to the same RASS score, they'll have a lower ICP with propofol than they would Ativan or Versed or any of those other benzos that we have. One of the other reasons that we don't like benzos is because when it's time to get these patients off, it doesn't come off very well. You can't do a very good neurologic exam because it kind of builds up in their system, so that's not good. But also, when you give morphine, when you give Versed, when you give Ativan, you have a much higher rate of delirium. And that's not something that you want to have to deal with if you can in a traumatic brain injury patient, because you don't know if it's their brain injury or if it's delirium. Okay? So you want to minimize that as best you can. Hyperventilation. Hyperventilation is controversial. It used to be that anytime a patient came in, we would just bag them down. Oh, the ICP's up, let's bag them down. And it works. You can take a patient who has an ICP of 25 or 30 and start bagging them, and their ICP it'll just tick right on down. The problem with it is that, number one, if you continue to hyperventilate them, that effect goes away. That's number one. But number two, and probably the biggest problem is that the way this works is that when you hyperventilate someone and you're driving down the CO2, what that does is it causes those blood vessels, the arteries, to vasoconstrict. And that's how the ICP is going down, is you're decreasing the amount of blood flow to the brain. So you can actually worsen your patient's outcome by doing this. So we don't hyperventilate patients anymore. It's not done in the modern setting. Don't do it. You can do it if your patient is about to, if you think they're about to herniate and you're on the way to the OR to do something else. But that's about it. It's kind of a last-ditch effort before you do something else. So what we recommend, or what I recommend, is that you just maintain the CO2s between 35 and 40, that low end of normal. That's going to be your best bet. Mannitol. Mannitol is one of those drugs that we use. It's an osmolar diuretic. So basically what it does is that we give it to the patient and it draws fluid out of that swollen brain. So it actually pulls the edema out of the edematous tissue. The effects are pretty rapid. As soon as you give it, 1 to 5 minutes later, it'll start doing its job. The way we load it, or we do load it, we give them somewhere between 25 milligrams to 1 gram per kilogram initially, and then we put them on a maintenance dose of 0.25 to 0.5 grams per kilogram every 4 to 6 hours as needed. We do it as a bolus. We don't do it as a continuous drip. And then we monitor serum osmolarity, because that's an important thing to monitor for these patients. You don't want to dry them out, too much. We don't use mannitol in hypotensive patients because you're drawing fluid out. It'll make them more hypotensive. Okay, so we don't use mannitol for hypotensive patients. What we do use for hypotensive patients is hypertonic saline. And so that can be anywhere from 1.5% normal saline up to 23.4% normal saline. Typically what we're using is 1.5 to 3%. So what we'll do is we'll give them a 250 cc bolus of 3%, and then we'll run it at 30 cc's an hour for, continuously, and kind of follow their serum sodiums. Our goal is to maintain a sodium concentration between 150 and 155 at the max. And the reason we like this is because it raises their MAP while decreasing their ICP. So their cerebral perfusion pressure theoretically should be getting better. Paralytics, the last part of our first tier therapy, is something that we use when none of these other things have worked. All right, so sedation's not working, pain medicine's not working, osmotics are not working. Okay, let's go to paralytics. So obviously, the patient has to be on the ventilator. It's an adjunct when sedation, pain management, and those osmolar therapies are not controlling the ICP. We use either vecuronium or cisatracurium. I like cisat because it's quick on, quick off. The problem with paralytics, though, is that you lose your neuro exam, clearly. I mean, you don't have one if you're being paralyzed. The other problem with paralytics is that you have a higher rate of VAP because patients aren't coughing, they're not clearing secretions. Even a patient that's ventilated, if they're not paralyzed, can cough and help clear some of the secretions. So you do have high rates of VAP. Tier 2 therapy, barbiturates, penobarb, comas are something that we use as rescue therapy for refractory intracranial hypertension. And the way it works is it both reduces the brain's metabolic rate, but it also reduces cerebral blood flow. So it's kind of that double-edged sword that if we don't have to use it, we're not going to use it. About 25% of these patients develop a clinically significant hypotension. There's zero prospective evidence that shows that this actually helps patients. It does drop their ICP, but it doesn't really translate into long-term outcomes as far as we can tell. So again, you have an associated loss of neurologic exam. You have to have an ICP monitor in to put them on penobarb. You also have to have continuous EEG monitoring. What we do is we shoot for burst suppression of about 10 per minute, which is the brain's not moving, is not active, not having very much activity. And we use the EEG to monitor and to guide therapy. So we'll adjust our dose of penobarb based on what the EEG shows. It has a very high risk profile. As sure as the sun rises tomorrow, all of these patients develop ventilator-associated pneumonia. And part of that's because the ciliary tract of the lungs just doesn't work when you get put on penobarb. It just doesn't work. The other problem is that not only do they can develop significant hypotension, which might frequently does require a pressor to keep their MAP up, but these patients have this habit of just going into asystole. So the problem with that is that it's not usually resuscitatable. It's just the nature of the cardiodepressant of the pentabarb itself that does that. But we use it from time to time. Surgical options, CSF drainage, we do that with our ventricular catheter. That's actually first tier, should be here as a second tier. Resection or drainage of the mass lesion. We talked about that earlier. If the neurosurgeon can drain something, and they should drain something, then that is what's done. Decompressive craniectomy is a little more controversial. It's actually a lot controversial. I think I've got another slide on that. I don't. It's a lot controversial. And the reason for that is that there's never been a study that shows that decompressive craniectomy actually helps patients as far as their outcome is concerned. I have a bias for that, though. I spent 12 years in the Army, 3 combat tours in Iraq and Afghanistan, and we did decompressive craniectomies, and it does help if you do it early, like very early, like very, very early. So when you talk about the literature that's out there, what they talk about early decompressive craniectomy, they're talking about decompressive craniectomies after the patient has reached a refractory intracranial hypertension point, so that ICP is greater than 20 and they can't get it down. And then sometime within the next 24 hours, they do the decompressive craniectomy. Well, the problem that I see with that is that, you know, if you stop breathing right now, how long do you have to, if you're not hot, if we're just breathing right now, normal air, how long does it take for us to actually suffer some kind of neurologic derangement related to just hypoxia of not breathing? 5 minutes, 10 minutes? 20 minutes, surely you're going to have some neurological deficit if you're going to survive at all, right? Well, what's the difference between that and then taking someone that has no blood flow or very limited blood flow to the brain and waiting 24 hours before you do the operation? So I think that it's my own opinion, no one else's opinion but mine, that I don't think the literature is very good on that. And I think that, you know, with my having seen it work in the past, my own experience, I think that the jury's still out on that, even though there's a lot of people that don't do it. We actually have one young neurosurgeon that will do it, and they'll do it early, but most of our older faculty will not, so you know, we'll see. Hypothermia, also controversial. Basically, the way that works is that it decreases cerebral metabolism by slowing or by cooling the patient down. The same way that we do it if a patient has cardiac arrest in the field and they come into the ER or in the hospital and they come in or they get resuscitated, we'll cool them down, right? We'll hook them up to the hypothermia circuit and cool them down. They keep them cold for, I guess it's 48 hours or so. And you know what? There's actually been about 12 or 13, maybe even 14 studies that have looked at this in TBI, and there actually is an improvement in mortality, and there's actually an improvement in neurological outcome, but it's very, very, very small. It's significant, statistically significant, but it's very small. So the problems come when you look at the studies and trying to read the variability and the depth and the duration of the hypothermia, and how much is actually, you know, how long do you keep them cold, and then how fast do you warm them up? There's also another caveat to that, is that patients who are TBI patients frequently have other traumatic injuries going on. They have their pelvis broken, you know, they've got their spleen that's come out, they have problems with bleeding. So you can't cool all of these patients down, because to make them cold actually increases their mortality from a general surgery trauma perspective. So it's, like I said, it's controversial, but hopefully, maybe one day we'll figure it out. This is Columbia University's stepwise protocol for ICP management. They're very aggressive with their surgical decompression. So if they see someone that has this cytotoxic edema and they've got the shift and all of it looks bad, impending uncal herniation, they'll go ahead and decompress them. Sedation, CPP optimization, that's your pressors to get that CPP up. They then use their hypertonic salines and their mannitols. They hyperventilate the low end of normal, like I previously mentioned. Pentabarb is up there, and then hypothermia is their last ditch. But they start here, which is, again, my bias. All right, last couple slides. Future directions, Prehospital TXA. So this is a study that I'm actually the PI at UAB for. I told you it was near and dear to my heart, right? Right, okay. So essentially, the whole idea of TXA in the field for TBI is to see if we can prevent some of those bleeding things from getting worse as soon as we possibly can. So patient is in a motorcycle wreck in Florida, so he's not wearing his helmet. Or in Alabama, and he is wearing his helmet, whatever. He's got this big brain bleed, okay? So the ambulance crew comes up and he's got a GCS less than 12, okay? They come on to him and they're like, all right, he probably has a TBI. Let's go ahead and start this medication and see if it doesn't reduce or help with the amount of bleeding that they're already experiencing. So we've completed the study. This was actually done here in the Birmingham, Jefferson County region, where we used a exemption from informed consent design, so that if you were a patient that one of our trained EMS units came upon who had a significant traumatic brain injury and you didn't meet any of the contraindications to the study, of being enrolled in the study, they randomized patients to standard of care, which is just supportive care, versus trying this TXA. So for those of you who don't know, TXA is tranexamic acid. It's basically a drug that helps in the fibrinolytic pathway of breaking down blood clots. So it doesn't form clots, okay? It's not like giving them FFP or activated prothrombin complex or any of those things. What it actually does is it prevents the clot that's there from being broken down, okay? So they would give you this TXA and then we're following patients out. We're hoping to have this data published by the end of the year, but it's still in analysis right now. Our ultimate goal was to look at this outcome score of how well people did as far as recovery is concerned 6 months after their injury. We're also looking at CT scans and labs and all kinds of other things, so more to come on that. But that is something that we're trying. Hopefully it'll show something good. Hopefully it won't show that we hurt anybody. We'll see. And then hyperbaric oxygen is the next newest thing. Hobbit, that's another study that we're participating in. I'm a co-PI on that. And basically what we're looking at is to determine whether or not we take these very sick patients and then dive them into a dive chamber, hyperbaric oxygen chamber, and see if that actually helps with their outcome. And there's actually some anecdotal evidence that suggests that it might. The problem is that the trial design is incredibly complicated. Taking a patient that's ventilated, has 5, 6, 7 trips, down to a one-man dive chamber, diving them by themselves, chest tubes, all the other things that patients have who are trauma patients, and seeing if they get better it's just complicated. It's not impossible, but we're just getting started on that, so hopefully we'll have some answers for you later on in a couple years about whether or not we need to be diving all of these patients. And that's all I have for you. I'll be happy to entertain any questions.
Do you have any hyperbaric rooms or anything?
We don't. We don't have the big chambers like they do at some facilities. We have individual single-person dive chambers that the patient just lies down in. It would be much better if we could dive the whole team, but we don't have that option.
What do you do with people